Hello friends, I am Dr. Aksa Kayyum, FCPS gynecologist. Let's discuss cervical cancer screening and colposcopy. What are the causative agents? They are divided into high risk types and low risk types. High risk types includes HPV 16 and 18. 70% cases of CIN and CS cervix are with HPV 16 and 18. HPV 18 is more specific with CS cervix adenotype. And the low-risk types includes HPV 6 and 11. It causes anogenital warts, condyloma acuminata, and laryngeal papillomatosis in newborn. As CIN, cervical intraepithelial neoplasia arises in the transformation zone of the cervix. Squamo-columnar junction moves out under the influence of the pregnancy, puberty, and OCP. So, what is the pathophysiology of HPV? When the woman acquires HPV infection, almost 80 to 90% of the women clear infection in 2 years. But in some, infection remain persistent. That leads to the HPV DNA integrates into the host DNA. There it leads to the oncoprotein synthesis, and that causes dysplastic vaginal epithelial cells. That leads to cervical intraepithelial neoplasia, and that leads to the cancer. So, cervical cancer screening. And the concept of the screening is early diagnosis and the treatment of the cervical intraepithelial neoplasia. So, what are the methods of the screening? These are the pap smear and HPV DNA test. In pap smear, sample taken from the transformation zone and the endocervix. Samples are taken with air spatula or the cytobrush. Slides are made, but these slides are not allowed to air dry. Immediately put in the fixative, and the fixative used is 95% ethanol. Pap smear sensitivity is 55% and specificity is 85%. It means if the pap smear becomes positive, it cannot be ignored. Liquid-based cytology advantages are in this clearer slides are made, chances of unsatisfactory smears are less, can do HPV testing on the same sample. So the pap smear report can be negative for the intraepithelial lesions, that it shows reactive cellular changes or inflammation, or it shows epithelial cells abnormalities that are squamous and glandular. Squamous includes ascus. Ascus is atypical squamous cells of undetermined sequence, and atypical squamous cells, mild dysplasias, that is low-grade squamous intraepithelial lesions CIN1, moderate to severe dysplasias, high-grade squamous intraepithelial lesions CIN2 and 3. So what is the screening protocol and when to start? Screening is started at the age greater than 21 years, irrespective of the age of onset of the intercourse. Let's say if the woman who had intercourse at 18 years, when will her this screening will be started? Her screening will also be started at the age of 21 years. And the repeat pap smear is done 3 yearly, and the co-testing that includes pap smear and HPV DNA testing is done 5 yearly. And it begins at the age of 30 years because 80 to 90% of the infection cleared in 2 years. So if we start co-testing before the age of 30 years, many women will become false positive and become falsely treated. And when to stop screening at the age of 65 years if regular screening is normal in the past 10 years. Total hysterectomy for benign cause has done, then no screening is required. HIV positive women required screening annually. In HPV vaccinated women, cervical cancer screening is required. So what is the colposcopy? Colposcopy is the examination of the cervix under magnification. In this, vulva and vagina can also be seen to identify the abnormal looking area and take biopsy from that area for histopathology. It is the diagnostic procedure. In this, the patient is placed in the lithotomy position, like during a pap smear, and then the speculum is introduced and the cervix is visualized. Then we apply the reagents on the cervix that includes acetic acid or the Lugol's iodine. With acetic acid, abnormal area appears white, and with Lugol's iodine, abnormal area appears yellow, and normal area it will stain brown. Colposcopy is usually done after the abnormal pap smear report or the HPV DNA test is positive. Abnormal areas are seen in the form of the punctuations that are abnormal vascular patterns. It could be fine punctuations or coarse punctuations. Fine are seen in the CIN1, that is low grade, and coarse punctuations are seen in the high grade, that is CIN2. And the mosaic pattern, it is in the form of the tiles separated by the white lines. It is also fine and coarse. Fine is seen in the low grade and coarse pattern is seen in the high grade. If the atypical vessels are seen, that are comma-shaped, irregular, bizarre-shaped vessels, these are strongly suggestive of invasive cancer. So what is the clinical colposcopic index, also called as modified Reed's index? It is the four criteria scoring system designed to standardize colposcopic assessment and guide biopsy decisions. It evaluates lesion margins, color, vessels, and iodine staining. And then we can evaluate the score. If the score is 0 to 2, it is HPV or CIN1, that is low grade disease. If the score is 3 to 5, it is CIN1 or CIN2, intermediate grade disease. If the score is 6 to 8, it is CIN2 or CIN3, that is high grade disease. So let's discuss one of the scenarios that the patient age is 35 years and she's complaining of postcoital bleeding. Physical examination is normal. What is the best step in evaluating this woman? That is colposcopy. Cause patient is symptomatic and pap smear sensitivity is only 55%. And HPV sensitivity is more than the pap smear, that is 93%. If you like this presentation, do share and subscribe. Thank you.